Assalamu alaikum. Thank you very much for all the attendance, and thank you for joining us. We'll be sticking to English during this online workshop since we have a lot of attendees who are non-Arabic speaker. I would like to start off by introducing myself. Dr. Sarah Aldakil. I'm an intensive care internal medicine consultant at King Abdulaziz Medical City National Guard. And I would like to also introduce my colleague, Mr. Tariq Al-Shahri. He's a senior respiratory therapist at the National Guard Hospital too. And we've been working over the past few weeks on the helmet experience with our patients at National Guard. So basically, the aim of this presentation today is to work as a second part for the ongoing educational material regarding the helmet ventilation. I believe most of you had already attended the lecture of the indication, the study, the evidence behind the helmet ventilation, moderated by Dr. Arabi and presented by Dr. Chris and Dr. Fito a few days ago. So we'll go over the objective of our workshop today, which is basically to review some of the indications and the contraindications of helmet ventilation, helping you preparing, applying, and troubleshooting the helmet ventilation interface, and also how to monitor and care for your patients while they're on helmet ventilation. So we're on the same page. I would like us all to meet the helmet. So the helmet that has been distributed all over the kingdom is the sub-salve helmet, which you see the picture of it right now. So basically it's a transparent helmet or bubble, and it has a base, which is the white one, which is very flexible, and a neck collar that is adjustable and made of latex or silicone, and two shoulder straps. I'll take you to this diagram to explain a little bit the components of the helmet. As you can see, and as we mentioned earlier, it's basically composed of vinyl hood that constitutes a 360 transparent window around the patient, and latex or silicone neck seal, as we mentioned earlier. And there are two ports in here for air. One is an inspiratory limp, and the other is an expiratory limp. And this thing in the middle in here, we call it the patient access port, which is basically closed when not used with a plug or a stopper. And these are the two shoulder straps. So this is the basic component, or what the helmet is made of and how it's designed. This helmet can be functional via different systems. Maybe some of you has gone through the literature and you've heard that some of the helmets are actually connected in the patient wards, where they basically use this system utilizing the medical air and the oxygen in the wall without a need for any ventilation or ventilator systems. And this is the second system, which we are going to be talking about basically, and we're recommending its use in the kingdom, which is basically utilizing a ventilator. So if you zoom in, as you can see, the ventilator is here, the inspiratory limp is connected there, a filter is connected to the expiratory limp only, and then the expiratory tube is connected. And we're going to go into more details later into these connections and how we can troubleshoot some of the problems. So let's go over some of the practical application pros that we're going to summarize in our presentation today. So when is it your choice? So we recommend using the helmet as an oxygen delivery system in acute hypoxic respiratory failure, regardless of the etiology. When you're facing a patient who's saturating less than 92%, or at an increased work of breathing state, either despite receiving nasal cannula or a face mask, so you escalate to the helmet, or they are failing other positive non-invasive ventilation, such as the high flow nasal cannula or non-rebreather mask. Also, you have to ensure before deciding that your patient will go into helmet ventilation that they don't have any of the contraindications, which are classically identical to the contraindications of BiPAP or other non-invasive modalities. If you think about it as ABCs, if they are not able to protect their airways because of a depressed level of consciousness, or because they are vomiting, or there is blood, or basically they have tracheostomy, or if they have severe respiratory distress that they actually might require an immediate intubation, or as of Cs, if they have very severe hemodynamic derangement or severe arrhythmias, and other causes that are, or etiologies that are particular to the helmet itself, such as the raised intracranial pressure, because this helmet is going to be placed around the neck. So in cases of increased ICP, it might compromise the venous drainage and might actually make your increased intracranial pressure worse. Again, patient refusal. Some of patients, when you explain to them, they might not like the idea. So you have to go through this contraindication list before you actually decide to apply the helmet. If you decide to apply the helmet, the patient needs to be in a monitored area with a minimum monitoring of oxygen saturation, heart rate, and blood pressure. Currently, in our institution, the helmet is only applied in critical care settings. So you decided that your patient is a candidate, and you are proceeding with the helmet application. So the first step should be patient education. This concept is very new to most of our patients, and that's why the helmet has to be explained to the patient. How does it work? How is it applied? And how is it removed? And how the patient is going to be sustained on the helmet. Also, the patient needs to be aware of the sensations and the feeling that might be experienced upon the mask application. So as the mask is being applied and as it's getting inflated, the patient might get some sort of tightness sensation until the flow and the helmet inflates. Also, ear pressurization sensation, because we are submitting the entire head to positive airway ventilation. So the patient might develop a sensation similar to what happens during takeoff or landing in the airplanes or during scuba diving, and they should be aware of it. The second step is for you to choose the helmet size. Currently in the kingdom, the helmet is available in 4 different sizes. And we recommend using this guide to decide which size is suitable for your patient. In case of a rush, I would say like roughly a small size lady will be okay with a small size helmet, and big overweight gentleman might require an X large. Most of the time, if you choose the size correctly, you might not need or require any further adjustment, but sometimes you might need to modify the height and the width of the neck, because as you see, there are ranges for the neck circumferences. So you might need to trim for comfort. So we recommend that this trimming process gets performed very accurately, as if you actually induce a seal a break in the rim of the collar, that might lead to tearing the whole collar and eventually losing the whole helmet, or creating folds in here that's going to prevent you from obtaining optimized seal around the neck. In terms of the equipment required during the process of helmet ventilation, you need the helmet, and you need inspiratory limp, and you need an expiratory limp connected to a filter, and of course the ICU ventilator. So the ventilator could be a conventional ventilator, or it could be the BiPAP V60. This is how you actually perform the connections. So inspiratory limb, and both goes to the ventilator. And we recommend that you actually test the helmet inflation before you apply it on the patient. So what we recommend you do is that you start the ventilation, you hold this part tightly closed and see that the helmet actually completely inflates when the flow goes into the helmet. So you ensure that there is no manufacturing errors or a leak in the helmet after you have applied it on the patient already. In terms of how you apply it, we recommend that it is applied by two healthcare providers standing at the opposite sides of the bed. However, it can be applied by a single person, like you see in this video. And you have to be very careful if the patient has any tubes connected to the neck or a nasogastric tube, so it does not get dislodged or removed accidentally while this is being applied. After you apply it, ensure that the collar actually folds into the inside against the neck, not to the outside the helmet. And you should be running your finger around the collar between the neck and the collar, so you ensure that it lays flat against the neck. If there are any folds in here or any gaps, then probably you won't be able to achieve the adequate seal. So that would lead to you unable to maintain the required PEEP. If that happened, you might have chosen the wrong helmet size, or you might require a little bit of trimming, as I've shown you earlier, to optimize the seal around the neck. Finally, after you have applied it, because we're going to insufflate air into that bubble, that would lead to upward movement of the helmet. So it needs to be stabilized either around the patient shoulder under the arms, or if it's going to be used for a prolonged period, to be actually attached to the side rails or the bedside. So now I will ask my colleague, Mr. Tariq, to speak to you about the ventilator setup and how to optimize the patient experience on the ventilator.
Thank you, Dr. Sarah, for all this information. Now, after you're already starting and establishing the helmet and make sure this is the right size for the patient, we might go to the important part with it, which is the ventilator setup. Now, we recommend to use it always with the ventilators. Yes, there is approach that you could use it with the non-invasive machines. But for now, we would like to focus on how to use it with the ventilators. In this demonstration, I choose the Perempinit 840. I believe this is the most common ventilator around. I know there is other machines, but this could be the easier for the presentation. In your ventilator, you have to choose the non-invasive ventilation. I hope your ventilator does provide this. If some ventilators doesn't provide the non-invasive ventilation, you might have some problem with the compensation of the leak and the ventilator will not stop alarming. Here you could use the mode will be the pressure support mode. Trying to get this. So yeah, this can help me with. So because the type of the breath is going to be pressure support, avoiding using the CPAP with the helmet for now. This is very important point. Again, we have the flow cycling, and this ventilator is giving me the flow cycling. If you go to the ventilator settings with the non-invasive and the pressure support, the first part is to use the rise time. We like to use the shortest possible time we could use. In different ventilators, the names is different. You could use something like the pressure ramp or the slope time or the inspiratory time percentage, different names for different ventilator, but have the same concept. This is the time that you need to deliver the pressure you set for this patient. It's very important to make it as short or as speed as possible. Now you're going to use also the pressure support time. You're going to use something above the beep like 6. In this slide, I used like 16. So the patient is having 16 pressure support above the beep of 10. The pressure support is very important. So this is enough. You have to make sure that you have enough flow in the helmet to wash out the CO2. And depends on your patient later on for the monitoring. The sensitivity, we would like to use something like 2 or less in the flow cycling. Most of the patients, they might start with 100% of IO2. Actually, when we start the helmet, most of the, with our experience, most of the patients, they always having the highest FiO2 before using the helmet. So the 100% is always required. PEEP, we recommend to use PEEP 10, a minimum PEEP of 10 in this case, to start helping the patient with the helmet. Now, the other part or the other parameters here is the expiratory sensitivity or the inspiratory cycling off in a different machine. This is the parameter when you use it when the machine decides to give you or switching between the inspiratory and the expiratory cycling. 50% is required for now to help the patient let me see this. This is to help the patient to avoid the asynchrony, and you can adapt this one later. We didn't, with our experience, we didn't find that much changing here. Some practitioners, they would like to go down a little bit to 25%, but 50% was so fine with our experience. If you didn't choose the sensitivity around the 50%, if you're going hard, this might make some delayed with the ventilation. The inspiratory time or the time max, it's, we recommend to use it like 1.5. This is just to delay the cycling of the patient. Again, this is only like the initial setting you can use it with the patient. You might adapt with the patient comfort and change some of it. So this is like in general the whole picture of the settings with non-invasive mode and the pressure support with the non-invasive. And the most important thing is using the PEEP of 10 and 100%, which you can later on have some weaning. This is the summary of the setup, and I think it's going to be easy for you to use it. Now, again, if you have some shortage of the ventilators, you might use the non-invasive, but for the time being, we are recommending just to use the ventilator to use it with the helmet. Later on, when you start with the patients, the titration is depending on your patient status. Usually, we would have some target with the PEEP. The 60% of IO2, it could be possible as long as you achieve the 92% of the saturation. The most important thing here with the PEEP is the leak. The leak is killing the PEEP level. Even if you put PEEP level of 10 or 12, if you have some leak, and I can assure you have some leaks sometimes with the patients. Regarding the beginning, when you start, the patient always having some intolerance, you would like to take it off, especially when you start on and the helmet start to bump off. Sometimes the strap is not right, so the leak is always affecting the PEEP level. So always give some time until the patient is getting fine with the helmet. Make sure your saturation is above 92, and then you start to adjusting the PEEP. Titrating the PEEP every 5 minutes, it could be, but I would like to keep it some time before you start to touching the PEEP until your saturation really goes above the 92. Now, the pressure support, on the other hand, is very important here to wash out the CO2. If your patient is really more tachypneic, you can go up with the pressure support. Now, someone might look at the maximum pressure we could give in these ventilators. We couldn't find like that limit of how pressure you could go. But if you reach like something around 22 to 25, maybe this is already the maximum you can go. But once you start the helmet, most of the patients we saw in our experience, they get comfortable, and the decreasing of pressure support can help us later on with the weaning. Now the FiO2, also the target when we start the helmet, we should reach 60%. We are not in rush to use it, like once you reach the 60%, this is our target with the helmet. You can tell that the helmet gives you the benefit. That's why the first hour is very, very important for monitoring these patients to tell if your patient is getting the benefit of the helmet or not. Saturation, if you don't have any improvement, at least when you start with the patient for the first 30 minutes, the saturation doesn't go up and the patient is still tachypneic or acidotic, then you have to go back and check if this patient is getting the benefit of the helmet, or we have to choose alternative solution. Very rare of the patients, they cannot tolerate the helmet at all. Most of the patients, they get comfortable and they goes on with the helmet. Now, again, with the weaning part, once you reach the FiO2 60 and your patient start to getting less tachypneic, less than 30, then you might have to start, I might take the helmet off. This doesn't happen that quickly, but it may take a few hours when you reach this patient. Again, the respiratory rate less than 30 sometimes cannot be achieved with these patients because there's another part or another factor can affecting this. The patient might have some anxiety. The patient is very scared about what's going on. So I wouldn't give it that quick with the weaning. I will wait some time, especially if my saturation is going up more than 92, I will be very happy. The pressure support, also we can wean the pressure support gradually when we reach the respiratory rate less than 30 and the patient becoming less tachypneic. The FiO2, once you reach the 60 and less than 60, then you can go down with the PEEP as long as you're comfortable. Once you reach that point with the minimum requirement with the FiO2 and the PEEP, you might have you choose your alternative about the disconnection, either to put high flow or just oxygen with the regular face mask, as the patient is okay. Now, the discontinue sometimes it helps us for a few hours. Some patients, they require to put back the helmet back again, depending on the situation. But most of the patients, once we start with the helmet after a few hours and we do the discontinue, they don't really require going back to the helmet. So this is the part I would go back to Dr. Sarah for this.
Thank you, Tariq. It was very clear, inshallah, for everyone. So we will proceed and talk about how do we care for the patients on the helmet. The thing that we need to understand about the helmet in comparison with the BiPAP is that usually when we apply the BiPAP on the patients via face mask or via nasal or oral nasal mask, we usually provide the patients with break where we take it off and feed them or rest them because of the amount of pressure it exerts on their face. And the nature of the underlying disease that we usually treat with BiPAP, like COPD exacerbation and heart failure, are kind of a quickly reversible processes in comparison to the ARDS that develops with corona. So the whole idea of the helmet is that we should be able to keep the patient receiving positive airway ventilation non-invasively for the longest period possible. So if you look at the worldwide experience, some patients actually receive the helmet ventilation continuously for up to 9 days. The average in Italy and in Chicago is 48 hours. So the patient care is a very important component to be able to maintain the helmet ventilation and provide the patient with the opportunity not to progressing to invasive ventilation, i.e. intubation. So Actually, these patients can have central line while the helmet is applied. The central line basically can be lying between the collar and the neck. Sometimes we have dialysis lines, which are pretty rigid, so they can't be folded this way. So what we recommend is actually you go and attach extra tubing and just loop it around the patient ear, or you can even apply a tape and then the slack of the tubes comes outside the helmet between the collar and the patient neck. And this is also has to be carefully monitored when the helmet is being applied, so we don't damage or injure the line while we're applying the helmet, as we mentioned earlier. Ear pressure, which I mentioned earlier, that resembles the pressure that you feel when you're in a plane, is a common complaint. And some patients who actually describe that they have severe pressure sensation issues or pressurization issues during flight, sometimes those patients cannot tolerate the helmet. Some centers have chosen to provide the patient with ear plugs, and some ask them to just apply their earphones and run some music while the helmet ventilation is going on. With the setup that we are talking about right now, which is the use of a ventilator, it's not as loud as using the Venturi system that is not connected to a ventilator. One of the possible troubleshootings that might work or help is attaching the filter, another filter, to the inspiratory limb that works as a sound muffler. However, we recommend against using this routinely because of the severe shortage we're facing right now. And with our experience using the ventilator, the sound has not been a big issue because it's coming through the ventilator and not through the noisy Venturi system that does not utilize the ventilator. In terms of feeding, anytime you're accessing the helmet through the access port I explained earlier, the red one, you need to increase the FiO2 to 100%, because what happens when you actually open this stopper to provide any nursing care to the patient, you're going to deflate the whole helmet and you're going to lose your PEEP. So remember that you need to increase your FiO2 100% every time you access the helmet. The patient can receive sips of water through the helmet. So basically you open the access port, be sure and be careful not to lose the stopper or the plug, because if you lose it, then the whole helmet is useless, because you cannot maintain your PEEP because there is a big leak and you aren't able to seal it back. So what we recommend, the way you do it is you take the straw without the cup, you put it inside, ensure that it goes into the patient mouth, the lips seals around the straw, and then you put the cup. So there is no soiling while you're trying to put the or fit the straw into the patient mouth. You won't be losing liquid inside the helmet. So secure the straw first and then add the cup below. And the same thing, you do it when you actually remove the drink away from the patient. You remove the cup first and then you take the straw out, you put the plug, ensure the helmet inflates, and then watch the patient for a little bit and ensure they are okay on their previous settings. You can bring your FiO2 back to what he was or she was on. Same thing if you need to perform oral suctioning, same process applies. You remove it, increase the 100% oxygen, the flow to 100%, and then insert the anchor and suction the patient mouth if they have like saliva or stuff they need to get rid of. Sometimes you need actually to remove the helmet completely to be able to provide full care. So same things apply. Be careful with the lines. Have your alternative oxygen delivery system nearby, either high flow or face mask or a nasal cannula. Remove the helmet, do your care and put it back, utilizing the same process that we have talked about earlier. Anxiety is a major issue with this patient. Tachypnea could be due to the respiratory failure and the hypoxemia they have, or sometimes it's because of the well-known described phenomena of increased sympathetic tone and activity on those patients with COVIDs, and maybe there is a component of centrally driven tachypnea on those patients. We recommend in these situations to use small dose of sedatives, and our drug of choice is Presidix, because as we all know, does not depress or suppress the patient respiratory drive. However, we have to be very careful of the titration, and it should be started at a very small dose. Remember, those are patients who are not intubated, and we have to be very careful about heavily sedating them and dropping their minute ventilation. We recommend that the titration is carried out only by the physician. It's not like the usual thing we do in the ICU where we provide a range. If the patient requires more sedation, they have to be assessed by the physician before we decide that we need to increase the sedatives dose. Some centers might use Seroquel or quetiapine to also help the patient calm down, which we found works in a lot of situations. In terms of sleeping and proning, because this helmet does not have a rigid collar in here or a rigid base, a lot of our patients are able to sleep. This is actually one of our patients in the unit, and she's sleeping with the helmet on. And also because we are performing a lot of awake proning or self-proning, proning can be performed with this helmet on. There is not yet evidence about proning in helmet ventilation, but there is an ongoing studies and some published data about the feasibility of performing this. One of the commonest issues, especially with prolonged use on patients who stay on the helmet for 24 hours plus, is skin friction and pressure ulcers in the armpits and around the neck. So for the pressure ulcers and the burning sensation, applying a talcum powder helps a lot. And we recommend that to be part of the routine nursing care. In terms of the pressure ulcers under the arms, applying deoderms or some barrier dressings between the straps and the patient's skin might be helpful. Applying a towel where you roll it under the patient armpit and then place the strap might help. And in prolonged application, we recommend that actually the straps being attached to the bed rails or the side rails instead of under the patient arms. But we have to be careful that if the patient slides on the bed, you might have or develop a displacement of the helmet upward, or you might develop a seal. So each position you choose to apply your straps has its advantages and disadvantages. So we have to be careful with that. That actually brings us to the end of our presentation, and these are the references. And the whole lecture will be available on a website dedicated for helmet ventilation by the Saudi Council of Health Specialty. And it's also going to include the what we call handout, where all this data that we have with more details are in a PDF, are available, going to be available in a PDF document that's going to be online soon, inshallah, either today or tomorrow. And now we're going to start taking any questions or any comments. Okay, so I'll start by answering some of the questions that have been sent to us. Most of them has been already answered by the end of the presentation. So the one of the questions is that somebody was asking that they've been told or instructed not to use it with a ventilator. I think what they are trying to say is that we recommend against using the CPAP with the helmet ventilation, as Tariq mentioned, because the flow on the CPAP are not sufficient enough to flush out the CO2 out of the helmet. So there are concerns about rebreathing. So that's why we recommend when you set up your ventilator that the minimum flow is 60. We recommend starting at 80, and in our institution, we are starting as high as 100, just to avoid this issue with CO2 rebreathing. Another question, why don't we start reducing the PEEP first and then the FiO2 later? We always aim in our ventilation approach to our patient to reduce the FiO2 to less than 60% as soon as possible, because it has been proven that there are some serious side effects of oxygen therapy above the level of 60%. That's why we try to titrate the FiO2 first to less than 60. And once we reach that level, then we can start coming down on our PEEP. Tariq, there is the question, I don't know if you can help us with. It's saying some machines did not give a reading of flow. Is it okay, or we have to see the flow reading? Is it reusable or not?
Yeah, you're right. This is right. Some machines doesn't provide the flow reading. Actually, most of the ventilator doesn't. I think only few. That's why we could just use the pressure support to give, hoping to reach that level of the high flow to watch the CO2. I would like to use some other indicator here is your expiratory minute volume. If your expiratory minute volume is something between 15 or 20 or above, this can assure you that you are doing enough flow to watch the CO2 in the helmet. I can see another question here is about what about the feeding? Can we disconnect and connect again? Yes, we have this access. Actually, most of the patients, the ICU team will decide to make it MPO for the first day or the first 12 hours on the helmet, but we still can have some sips of the water during the access port. From our little experience for the last few weeks, yes, some patient after like 1 day of using the helmet, we could take it off and let them eat their meal as regular meal, and we connect it back. We never had any issue or difficulty with this.
Allow me, Tariq, I would like to add a point for that. Because the helmets, in theory, are designed to stay for a long time, and we would like to extend the use as long as the patient tolerates it. If you see that your patient is actually going to be one of those candidates, we recommend that you insert an NG tube for feeding. So we minimize the amount of time and frequency of removing and putting on the helmet back and forth. However, remember that when you insert the NG tube, you have compromised your lower esophageal sphincter tone. So ensure in these patients that you monitor the residuals, because especially if you're using high level of pressure support or PEEP, the risk of insufflation and filling up their stomach with air is higher, so you check their residual. But as mentioned for Tariq, yes, we can discontinue that if needed to feed the patient or to provide care. But as I explained earlier, the minimum, the interruption, and then if we work on the patient comfort until it's perfectly optimized, then we're going to minimize the amount of time and numbers that we remove and interrupt our therapy. Go ahead, Tariq. There is the question, next one for you, the triggering mechanism.
Well, mashallah, I can see like a lot of questions. Maybe I have the time only enough to answer all of them. Now, someone asked about if there is any risk of paratrauma or pneumothorax. We didn't experience any kind of risk or pneumothorax in the patient. Now, another question is it difficult with the triggering the machine when we're using the bi-level, putting in mind that it's yes, it's not at all difficult. Once you put the rise time on the lower, or the speed of the rise time the lowest as possible, and there is no difficulty with the triggering at all with the patient. It goes very well. And now another question here down about the possibility of the humidification. Yes, the humidification is a little bit challenging here. We didn't experience any difficulty or any complaint of the patient regarding not using the humidification. If you would like to use humidification of the patient, you have a lot of whatever is comfortable with you. Again, it's really a little bit challenging. If you're using the heated circuit, you're going to be having a lot of condensation and fogging on the helmet, which might have some discomfort on the patient. We try to use the HME as well. We try to use even if you want to use a cold humidification, not the heated. You could feed it in the circuit through the large volume nebulizer or even the bubble humidifier. But again, we are using most of the patients without humidification, and we didn't have that complaint of the dryness that much. I will.
You allow me, Tarek, I just wanted to highlight a few points with the humidification. Just to add to my colleague, looking at the experience around the world, apparently the most successful let's say, approach to humidification is humidification at room temperature or with a temperature that does not go beyond 27, 28. The issue was with the warming of the gas that leads to the fogging and the sense of the sauna around the head of the patient. So if in your system you could provide a cold humidification by attaching a humidifier and turning off the heater, that's an option. Or if you have one of the ventilators or the humidification system that you could actually control the temperature and put it to the lowest possible, that is the most comfortable experience for the patient. Running the ventilator at 37 humidification has resulted in extreme fogging and some discomfort down the road. As Tariq said, so far, most of our patients has been receiving this therapy without humidification, and it's been working well so far. There is a question here about comparing the Venturi system and then in non-invasive mode. We understand that both system works very well, but just for the sake of simplicity and to be in alignment with the national guidelines that is going to come up soon, we're gonna stick to in our educational programs to using or utilizing the ventilator, because the Venturi system is a very different setup and it's designed to be set up on the patient floor. And so far, as per policy, we recommend that those patients are managed in the critical care areas or monitor area. However, down the road, maybe with the increased requirement, the Venturi system can be utilized, but this would be out of the scope of this particular workshop. Can the pressure affect the eyes? So far in all the studies that looked into patient comfort, the eye complaint has never been a problem. Again, if the dryness is an issue, lubricant or eye drops can be prescribed for the patient, but the pressure is not that high that it actually affects the eyes. The risk of health worker contamination when opening the patient access port, of course, because you're actually, you're gonna deflate the helmet and the patient is breathing freely. So anytime you need to access the patient port, actually anytime you walk into the patient room, even if they're wearing a helmet, you should be on your PPE gear. When you remove it, when you put it back, when you access the port, when you connect the ventilator, any patient care provided for those patients has to be under strict PPE protection. Do you have any questions, Tariq, you would like to answer?
Actually, it's really, mashallah, a lot of questions I'm trying to catch. I have a question here. If you can use any ventilator with the helmet? Yes, we use all the ventilators we have on the helmet. We use the Bennett 840 and the Servo I and the Draeger P500, as long as it's provide non-invasive mode and the pressure support. Another questions, Well, I'm lost with these questions.
It's okay. Nebulizers with the helmet, Tariq. What do you think?
Yes, you can use the nebulizer with the helmet through the access port if needed. Um, One thing maybe we didn't mention it in the slide is the use of the. I think this is a very important point is the use of the helmet as a disposable or reusable. Actually, it's designed to be disposable just for individual patients, but in case of uh, shortage or in case of the wartime, as we call it, we could use it and for disposable. But this is you have to stick with your hospital policy if it can be sterilized again and use it again. From our experience in our hospital, yes, at the point we had to use it as a disposable with cooperation with the infection control department to sterilize it.
They were saying a question about the advantages of helmet over CPAP. As we mentioned, it's actually just the interface. As we mentioned that with the CPAP masks, either full face or nasal, oral or nasal, the pressure areas kind of compromised how long we can apply it on the patients. And the whole idea here is to provide modality of delivering a high pressure ventilation without having the pressure areas and needing to take these frequent breaks. Besides, if you're applying an oral mask or nasopharyngeal mask, maybe the feeding and oral care has to interrupt the whole treatment if we need to. Well, the helmet, you could still provide some minor patient care with the helmet staying on. Understandably, you might lose your PEEP a little bit while you're providing that. HME and the helmet, it has to be in a special connection way. The whole idea is that you don't want to communicate your inspiratory limb and expiratory limbs just for the sake of the infection control purposes. So the ideal setup with HME is not yet determined. We already answered this. From your experience, Tariq, how much is the helmet effective comparing to face mask or BiPAP with COVID-19 patients?
Actually, with our experience in our ICU, we see it's much better than the face mask, and yes, we see a lot of patients getting much better with the helmet, and we did avoid intubation in many cases. Actually, the intubation cases that we had after using the helmet was not related of patient getting worse on the helmet. I don't want to be that much optimistic, but I would say I never seen any patient getting worse after using the helmet. The intubation decision was for different reasons. One question here I would like to answer is about using the helmet with the different system than the ventilator, like the Venturi system. Actually, the decision of from the Ministry of Health for us to make this workshop was emphasized on using it with the ventilator only. The non-invasive, you could use it with the non-invasive machines like the P60 in case if you're shorted with the ventilator. But for now, our recommendation is just only to use it with the ventilator.
One question is, why are we using the ramp when we set up the ventilator?
Well, the ramp or the rise time or the speed. Now, this is very important for the patient comfort. This will decrease the work of breathing. So that's why, as we said, we like to use or just set it as speed as you can. The experience we had from the Italian experience on Chicago University is using like 50 milliseconds. This cannot be provided by most of the machines because they give you the percentage time or they give you the RAM pressure. Now, or sometimes in different names in other ventilators like the Draeger, they call it the slope time. So the very fast speed, this will decrease the work of breathing during the helmet, so it can be easy for him to trigger and have this pressure go past.
Okay, just because I'm having a lot of questions about the HME filter. So as we said, the whole idea of the HME is that you have to have the inspiratory and expiratory limb meeting at some point, so you could actually trap your heat and moisture, which is something we recommend against when we are ventilating COVID patients, because you want the expiratory limb to be separate from your inspiratory limb to filter the exhaled air as it's leaving the helmet. So at this stage and in the COVID era, the HME, we don't recommend using it. Could the helmet be an alternative to intubation? Actually, the studies, and I would refer you to Dr. Arabi's moderated presentation, talking about the physiology, but the whole idea is that in the studies, it showed that utilizing helmet ventilation has resulted in decreased rate of intubation in the intervention arm.
I have regarding this, someone asking about if it's possible to use it with the portable vent. Now, he gave an example about the Oxylog. Now, if the Oxylog can provide non-invasive mode and with the pressure support, I don't think it's that will be comfortable with the patient, because you cannot do that much monitoring with the Oxylog. Again, you have to watch your expiratory minute volume. You have to watch your tidal volume. Again, the tidal volume here is going to be very high, it's like 1,000 or more, because most of the volume is going to be lost on the helmet. I wouldn't really recommend using the Oxylog as in this case with the helmet. We would like to make it clear that use an ICU, classic ICU ventilator when you're using with the helmet.
I would like to just take a few minutes to show up the projected website on the screen. So this is the website that I spoke about in the introduction, which is the website dedicated by the Saudi Council to Helmet Ventilation, with all the resources that you might need to initiate your helmet ventilation program in your hospital. And the lecture that I mentioned, which is part one of our series of workshops, is uploaded there, which speaks about the pathophysiology and the evidence behind the helmet. And we're gonna add to the resources the handout notes from this lecture. So you have access to all the recommendations that we presented in this workshop today. So the links are going to be shared, or they are already shared with you down there. So feel free, please, to access the website and utilize the resources available. I think Tariq, Dr. Sulami, if you hear us, Dr. Sami Sulami is the leader of Health Academy in the Saudi Council, and we have the pleasure to have him with us. So if you have any comments that you'd like to share before we conclude this session.
الله يعطيكم العافية. جست أنا بقولها بالعربي يعني ريلي دي ألف شكر للجميع الحضور، يعني الله يعطيكم العافية. وهذه ورشة العمل هي زي ما حاولنا نخليها مور أكثر شيء عملية وبراكتيكالز، ونشرح بعض الأشياء يعني، وإن شاء الله كل شيء واضح في الصفحة هذه يعني. وإذا حسينا إن شاء الله في أهمية إن نعمل ورشة عمل ثانية، الورشة العمل هذه مسجلة وحنحطها كمان في الموقع، اللي حب يشوفها واللي ما قدر يشوفها واللي كان مثلا عنده الإرسال يقطع ولا أي شيء موجودة. وإذا احتاجنا نعمل واحدة ثانية وثالثة ورابعة، إحنا بالعكس إحنا نتمنى إن نساعد قدر المستطاع يعني. يمكن بس just re-emphasize جدا إنه يعني الهلمت is not replacing الانتوبيشن، الهلمت is not replacing هذا. الهلمت is supportive tool إن نقدر نستخدمها early. هل ممكن نبدأ نستخدمها من الطوارئ؟ الإجابة نعم، ممكن نبدأ نستخدمها من الطوارئ، وإذا كانوا في مرضى كثير needed في الطوارئ ممكن نستخدمها في الطوارئ يعني. لا بس that's all يعني صراحة. وألف شكر على جميع الحضور، وألف شكر دكتورة سارة، وألف شكر طارق، وألف شكر لمرتبة من ناحية تقنية الأخت جيهان.
Thank you, Dr. Sulami, again. And just to quickly repeat what Dr. Sami Sulami for our non-Arabic speaking colleagues is that this whole workshop is recorded and is going to be uploaded on the website. He did stress the point that this is not an alternative for intubation. As we mentioned earlier, one of the contraindication is that patient in severe respiratory distress should be intubated and should not be bridged with helmet, because this might lead to delaying a more effective and life-saving therapy on those patients. I guess we actually have come to the end of this workshop. We really appreciate your attendance. We really appreciate your interactions, and there is certainly a lot of questions that we would like to answer. Some of them are very interesting and we haven't touched on or upon during the presentation. We would like, probably you will find an answer for those questions in the handout that will be uploaded very soon on the website.
Just one, Sarah, if you can please, if you have any comment, you can just write it for us. Maybe you can write it in the chat as a question from now. If you have anything just for us, how to make this better next time, just please write it.
We do really appreciate your feedback, and I would like to ask to also thank my colleague, Mr. Tariq, for his invaluable contribution, and also Mrs. Jihan, our coordinator in here. Thank you very much and have a great night. And thank you again, Dr. Sulami, for joining us.
الله يخليك. شكرا.